today with a remarkable collection of speakers whom I'll introduce in a few minutes. Zahir Salul, Jason Cohn, Mark Swain, and Ben Taub. My colleague, Rebecca Hirschman, originally was going to host this session, but for personal reasons is unable to do that, but I want to acknowledge her many contributions to this and the regrets that she conveys that she's not here with us. And special thanks at the outset for several people who've been most integral to the work that we've done on this particular topic, most importantly, Chris Millard from our staff, from the International Security Program, Sarah Minot. Special congratulations to Kath Hicks, Melissa Dalton, and all of the International Security Program staff for pulling together this Global Security Forum here today. Why are we doing this? We have been working for the past 5 years pretty actively on this topic. I think it's fair to say that while we're aware of the magnitude of the problem, Syria, as the Syria crisis escalated, as war broke out in the spring of 2011, and then in the course of, very rapidly over the course of the next year, year and a half, things escalated dramatically. It brought to our attention just how egregious and flagrant the violations were of the neutrality of humanitarian operations and the deliberate targeting of the health sector as an act of war, as a strategy of war emerging, and that this had profound consequences it had profound human consequences for patients, for civilians, for health workers. It had profound consequences for infrastructure, health infrastructure, for the space for humanitarian organizations to operate, and it had profound implications for the normative realities of the Geneva Conventions and the constraints that are supposed to exist to bring about greater accountability and protections and respect of neutrality. We also began to acknowledge that this problem is one that has spread across multiple countries and is a very long-term problem with several factors driving it. So this event today follows on the heels of multiple events. We've drawn over the years, and we're very grateful for the support we've received from many parts of the United States government, from the Department of Defense, represented here today, Mark Swain, from UN, from the Population, Refugee, and Migration Bureau at State Department, from Jeremy Konendijk and his colleagues at USAID, the Office of Foreign Disaster Assistance, from the White House, and from CDC. At 11 a.m. we'll be hearing from Dr. Tom Frieden, Executive Director of the CDC, on the Global Health Security Agenda. This figures in some ways in that, and we've been very grateful to the close relationship we've had over the years on these issues. We've also benefited from many of our friends, some of whom are speaking here today. Zahir Salul from the Syrian American Medical Society. MSF has been a particularly important partner, the International Medical Corps, WHO, and the World Bank. Many friends like Len Rubenstein, who I believe is with us today, from Johns Hopkins University, Susanna Shirkin from Physicians for Human Rights, and journalists. And we've got the good fortune today that Ben Taub, a contributing writer to The New Yorker, is with us. Journalism has played such a very important role. We're going to begin this morning with a 3-minute trailer to a video documentary that we are putting together. Justin Kenny, an esteemed, accomplished producer, has joined with us and is with us today. Justin Kinney has partnered with us in pulling this together. Paul Franz from our staff at our Ideas Lab as an editor and producer has been very integral to this, and my colleague at the Global Health Policy Center, Chris Millard. You'll see that this is just a reminder of what's forthcoming. It's a 3-minute video. The larger product will be a documentary film that will issue early in 2017, approximately 40 minutes in length. This is a bit of an experiment for CSIS to be doing long-form video policy work. In April, we released a video, Ebola in America, an epidemic of fear, which was the first experiment. We would welcome your feedback as this product evolves, particularly on placement and ways to reach new audiences. With the Ebola video, we were successful at building interest at places like the museum, at the Smithsonian. It's going to figure in a CDC exhibit in June of next year. And we've reached a variety of audiences, and of course it's available online. But 30 or 40 minutes of video has to be gripping, and you have to have an audience that's really quite committed to this. So what I suggest we do is let's watch the video, and then I'm going to invite our speakers to come forward and join me. I'll introduce them, and then we'll move right away into hearing from them. We will have a discussion after that, and we will then move into providing an opportunity to hear from you as part of this effort. So thank you all for joining us, and again, thanks to those online. Chris, thank you so much. Why don't you key it up, please?
The war in Syria represents a new low for the international community. We're seeing a war without law, as well as seemingly a war without end. It's very, very striking that we're living in an age of the bombing of UN convoys, never mind the targeting of hospitals.
So we were so surprised and shocked when we saw our colleagues covered with their blood and giving their last breaths. I don't know how to describe that. It's so hard emotionally. It's like you are
The war in Syria represents a new low for the international community. We're seeing a war without law, as well as seemingly a war without end. It's very, very striking that we're living in an age of the bombing of UN convoys, never mind the targeting of hospitals.
So we were so surprised and shocked when we saw our colleagues covered with their blood and giving their last breaths. I don't know how to describe that. It's so hard emotionally. It's like you are losing one of your precious in front of your eyes.
We're witnessing a profound surge of violence against civilians, against health workers, patients, facilities, humanitarian convoys across a full spectrum of countries that is really shredding the accountability and protections that are contained in the Geneva Conventions.
The attack on Kunduz was a sustained attack over an hour, despite the fact that all the parties knew us, had our GPS coordinate. We must say that it was our biggest loss in terms of lives. 42 people died, 14 of our staff.
This was a tragic mistake.
This is a period when there's the danger of vacuum around the world and a danger for the abuse of power by states that are strong enough to do so. The international sense of conscience and consciousness that led to the responsibility to protect in the early 2000s has certainly been eroded.
People are struggling to respond. They're building clinics and hospitals in underground bunkers. They're documenting these attacks and publishing them. They're taking measures to the UN Security Council.
Stop bombing hospital. Stop bombing health workers.
But up to now, these measures have not had much effect in deterring attacks. But many courageous individuals and groups continue the fight. This is a fight that's going to last well into the future.
We believe that war stopped at the door of our hospital, and we want to preserve that. And we want to preserve access to health care in war zones. That's a battle that's worth to fight.
Let me invite our speakers to come up and join us. I apologize, the sound was not what it should have been on that. We can show this video again with adequate sound after the panel. If for those of you who care to wish to see it again, and it's going to be posted online on CSIS as well as YouTube, and so it's accessible there as well. Thank you. So let me just quickly introduce our speakers. Jason Cohn, to my right, is the Executive Director for Doctors Without Borders in the United States. He's been in that role for 18 months, a little more than 18 months. He's been very generous to us over the last several years. And this has been a tough period. Not that any period is not without serious challenges for MSF, but you've been in a period where significant attacks upon facilities in Yemen most recently, the Kunduz attack in Afghanistan in October, continued numerous attacks in Syria and elsewhere. Jason began his career in reproductive health and began his career with some training at the Transnational NGO Leadership Institute at the Maxwell School, Syria University. You know that school is embedded here at CSIS. So you're an alumni of us, in a sense. He's been very prominent during the West African Ebola outbreak as communications director, very active during the Haiti earthquake. Extensive involvement in looking at operations in South Sudan and in Myanmar. I think, as we talked about, the South Sudan work was triggered by the awareness that the environment was changing significantly, and that folks needed to take a new and very careful look at the way that operations were organized and relationships structured and the like. So thank you, Jason, for joining us. Mark Swain, to Jason's right. Mark is the Acting Deputy Assistant Secretary of Defense for Stability and Humanitarian Operations at the Department of Defense. That places him with lead responsibilities around humanitarian assistance, stability operations, peacekeeping, international rule of law, prevention of atrocities, women, peace, and security. He retired from the Navy in 2008. He's occupied a long series of terribly important positions relative to Africa within the Policy Directorate at the Department of Defense, at the Africa Command, U.S. Africa Command, within the White House at the NSC, and we're delighted, Mark, that you could come today and be with us. Teresa Whalen originally was to come and speak, the acting assistant secretary in that office, and sends her regrets. She has to be at the Southern Command today, and Mark kindly agreed to be joining us. Zaher Salul, to my left, a Syrian-American critical care physician from Chicago, immediate past president of the Syrian-American Medical Society, and remains very deeply tied to the work of SAMS, was a founder and a lead advocate in pulling together a broader coalition, the American Relief Coalition for Syria. As we'll hear from him, the level of effort, and mobilization and delivery of services in Syria and in the neighboring countries is quite extraordinary, and much of that can be ascribed to his leadership, his commitment and courage over these last 6 years. He's a practicing physician in pulmonary critical care medicine. And to his left, Ben Taub, a contributing writer at The New Yorker, freelance contributor. He's been writing on a wide array of issues. He came to our attention initially in a series of pieces that he did on Syria, on the medical community and the efforts underway in the medical community in Syria to retool and to cope with the assaults and the requirements that were emerging as civilians were being targeted. The work that he did on the Assad files, this remarkable instance, we'll hear more from him about this remarkable instance of a somewhat subterranean mobilization to document the abuses and pull forward Syrian government documents themselves into that archive, which will prove to be, I believe, quite important into the future. I've asked each of the speakers to come prepared with to answer some specific questions relevant to where they sit in the work that they do, and I'm going to ask Jason to kick things off, and then we'll move to Mark, Zahir, and Ben, and then we'll come back for a further discussion, and we'll come to you for your comments and questions. So welcome all of you. Jason, why don't you kick things off?
Thank you, Stephen, and thanks to CSIS for making space for this critical issue. As you noted, unfortunately, we've had to have a lot of panels on this topic in the last couple of years. It's interesting of note, I think, during the keynote address earlier this morning, former Secretary of Defense Panetta, in talking about sort of national security issues, talked about the importance of drawing lines and making sure that certain lines, when it comes to peace and security, are not crossed. And for a very long time, the international community has drawn a very clear and bright line around attacking healthcare and hospitals in conflict. But unfortunately, we've seen in recent years a bit of in some cases, a race to the bottom in terms of a lack of respect for that very specific and bright line of not attacking hospitals, threatening doctors and hurting patients in hospitals. Attacks on the medical mission continue with impunity from places as well as Yemen to Syria. We're really facing a systemic problem. In Syria, the bombing of health structures in rebel-held territories is an integrated component of the war strategy pursued by the government of Syria and its allies, such as Russia. And to be sure, opposition groups operating in the country also demonstrate very little respect for the medical mission. In Yemen, attacks on protected medical facilities and people are part and parcel also of that all-out war there, characterized by somewhat of a negligence and loose rules of engagements by the Saudi-led coalition and as well as its opponents on the ground. Some states, the rules of engagements and protocols surrounding the conduct of hostilities have also eroded the protection of health structures. The question, I think, at the beginning, though, is, are things worse than ever? It remains really difficult to speak about trends as we really lack historical perspective when looking more than a few years back. We remember the attacks that have happened in places like Afghanistan, Vietnam, Bosnia, and elsewhere, Chechnya. The Safeguarding Healthcare Coalition, International Committee of the Red Cross, World Health Organization have all made recent efforts to try and document the extent of these attacks, and they're doing very good work to try and to fill that void. My organization has documented at least 50 attacks on 21 of our facilities or supported structures in 2016 alone. And then last year, there were 106 attacks on 75 MSF and MSF-supported hospitals. 63 of those attacks took place in Syria, 5 in Yemen, 5 in Ukraine, 1 in Afghanistan, and 1 in Sudan. So you see multiple attacks on the same structures happening in Syria. So this is really a carnage that we're seeing playing out. It's an incredibly alarming rate of these attacks in the last years, and we're really at quite a deadly impasse. As a medical organization on the front line, along with other groups like SAMS and others who work in the field, we no longer can assume that fully functioning hospitals in which patients are fighting for their lives are out of bounds. Hospitals and patients have been really dragged onto the battlefield, as we've seen quite egregiously. These attacks take different forms: bombing, shelling, looting of facilities or ambulances. In some cases, it's direct targeting of facilities as part of a war effort. In other cases, it's because of indiscriminate attacks that have failed to take the necessary precautions that are outlined in the Geneva Conventions to avoid harm to facilities and health workers and patients. And we see just direct violence inflicted on health workers independent of an attack on a hospital. militaries or armed forces taking over hospitals and fighting in and around these structures. Obviously, we're incredibly outraged by these grave breaches that we've seen, and we've spoken out quite loudly over the past several years on that, most recently at the UN Security Council when Resolution 2286 was passed back in May. While we see these aerial attacks as some of the most visible expressions of this assault on healthcare in places like Afghanistan, Syria, and Yemen, as I mentioned, the fact of the matter is that my colleagues in the field, and predominantly actually national health workers, are really the greatest threat from these kinds of attacks. Kidnapped, assaulted, threatened, harassed, just for trying to provide medical care. We've seen MSF hospitals robbed and ransacked, equipment looted or destroyed, patients killed in the beds of our hospitals. And this is across a wide spectrum of places as well. The Congo, Central African Republic, Lebanon, Honduras, Myanmar. We see places where combatants are really trying to threaten the way that doctors and health workers practice care in terms of on the basis of needs, so really attacking the idea, the principle of impartial medical care, the triage of patients based solely on need. We've repeatedly called on states to enact the very clear prohibitions on these attacks that are in international humanitarian law, in the Geneva Conventions that we've seen. The legal bar for determining the loss of protection of medical care is very high, and for good reason. Healthcare is really the last line of humanity in an otherwise inhumane setting of war. But in practice, the bar is clearly very low, given the widespread attacks that we've seen. And sometimes often unverified intelligence or mere claims that a hospital lost its protection is justification enough for attacking it. So what are the consequences? Regardless of whether attacks on medical facilities are intentional, reckless acts, or horrible mistakes, it really is the same in effect at the end of the day. The dead and the wounded in the aftermath of these attacks, but probably even more shockingly, is the invisible bodies that pile up in the weeks after, the patients that lost that we can't see, that we can no longer treat. The tolls are never limited to the immediate casualties, the loss of things like trauma care. There's also the loss of health services at the precise moment when care is most needed in a war zone. Expectant mothers die in childbirth. Children go unvaccinated or perish from treatable diseases like malaria or even simple things like diarrhea. Each new attack also depletes the ranks of local medical workers. We know they are the ones that most often are the victims. Yet they stay against all odds, as we've seen in places like East Aleppo, under incredible circumstances. And overall, it creates just a real sense of fear. We have patients who don't want to stay in the hospital to complete their care. They want to get out there out of there as quickly as possible, because they know now there is a target on health structures in many of the conflicts today. Steve asked me to speak a little bit about what are some of the most critical steps the international community can do to reverse this dangerous trend. Well, frankly, it comes down to really just implementing existing bodies of law. Nothing new needs to be written here. No new treaties need to be passed, conventions signed. It's all there in the Geneva Conventions. It's incredibly unambiguous. The protection of hospitals and health workers and patients is guaranteed in the international humanitarian law. And as I mentioned, the UN Security Council unanimously reaffirmed these protections with the passage of Resolution 2286 on May 3rd, 2016. So what we need is for those laws to be respected and for this security resolution to be implemented. So basically drawing, again, a really bright and red line against the attacks on hospitals, making sure that that idea, that concept, those protections are really codified in rules of engagement, standard operating procedures, and the practice of militaries in conflict, whether they be state actors or non-state actors. But when these attacks occur, and we've seen them obviously happen in an incredibly high rate, we do need to see independent, impartial investigations, and we do need to see accountability. Oftentimes, or at least as the universal rule, when an incident occurs, it should neither be the responsibility of the victims nor the perpetrators to establish and qualify the facts. But as of today, suspected perpetrators get away with self-investigating, and there's no independent follow-up for attacks. These ongoing attacks, they really demand accountability if they are ever going to stop. They must be credibly investigated. Investigations carried out by perpetrators of attacks, they're welcome, but they're insufficient. We can't have this continued situation. There really is a need for a dedicated mechanism to put in place to create political pressure for accountability. There is the International Humanitarian Fact-Finding Commission that was created to investigate these kinds of breaches of law, international humanitarian law. It's never been put into action. It was never activated. We've also, as an organization, and we said this at the Security Council, called on the UN Secretary General to establish a special representative on attacks on the medical mission to continue to track and give visibility at the highest level. At the end of the day, protecting the wounded and the sick and those who care for them is the last real front line for humanity and the otherwise inhumane and brutal reality of war. We're really failing those on the front line. States are continuing to proliferate these attacks, and it really needs to come to an end, but I'll stop right there, Steve.
Thank you very much, Jason. Mark.
Thank you, Steve. Again, thank you for inviting me here to talk, because it's very important for the Department of Defense to re-emphasize the importance of international humanitarian law and how we conform and comply with that. After the tragic mistake of Kunduz, that was a mistake made by our Department of Defense that resulted in the attack against the medical facility in Kunduz, and we claimed ownership and responsibility for that. And I think that, as Jason talked about, all of those many and too many numerous attacks on health facilities throughout the world since then, and even some before then, I think it's incumbent upon the international community to realize and put pressure on those responsible. And because we took responsibility for that, and I'll talk about some of the things that, one of the things that Stephen asked us to do was, what did we do to mitigate? How do we go forward? And that's what I'll focus my remarks on today. I want to emphasize again that we're strongly committed to upholding the international humanitarian law and protection of civilians, which includes impartial humanitarian personnel and facilities. Since the tragic mistake of Kunduz, we have taken proactive measures to demonstrate our commitment to international humanitarian law, including development of best practices that often exceed IHL requirements that can be used examples for other states. For example, when participating at the World Humanitarian Summit this last year in May, the United States joined 48 UN member states in signing a declaration affirming the importance and adherence to IHL, including the protection of humanitarian personnel, medical facilities, internally displaced persons, and unhindered humanitarian access. President Obama also signed an executive order this year that memorializes best practices developed by the Department of Defense that the U.S. government currently implements to protect civilians in the context of operations involving the use of force. The Department of Defense recently issued a statement of principles, and that was a direct result of the tragic mistake of Kunduz, and those principles on the protection of medical care during the armed conflict. These principles reflect existing legal protections and are drawn principally from the Geneva Convention. We take great care in our operations and training to mitigate the likelihood of civilian harm. We train our forces on civilian harm mitigation and continually seek to improve the implementation of our best practices. We also developed a robust system investigating credible reports of civilian harm so that we take more appropriate steps to address such incidents. Our training starts even before when I first joined the Navy, I flew in planes, and when I was in training in Pensacola, Florida, I was in a plane that did not have ordnance. But the first navigation route that I flew, they put a big circle around a facility and said, that's a medical facility. If you fly over that, you will get a down on this flight, and you won't graduate from flight school. So we learned early on, no one came and briefed to me, this is international humanitarian law. It was just that inherent understanding of who is a combatant, who is a non-combatant, and that in this business of the Department of Defense, we have to adhere to that and understand that. So I say that to the people who have never served in the military to think, how could this happen? This was a mistake in Kunduz. And I also want to explain that when you train in the military, you get international humanitarian law training later on. When I was in A6s and F-14s, before we went on deployment, we've got lots of briefs of what we can and cannot do. But that understanding and training and respect for the medical facility and non-combatants is inherent in our training throughout the military. So I just want to highlight that point because I think it's important to realize that this was going on for years and that what happened in Kunduz was a mistake. So for our mitigation and reduction, what have we done with that? We certainly comply with the principle of distinction and to respect the principles of humanity, neutrality, and impartiality and independence for the provision of humanitarian assistance. Efforts to respect and protect impartial medical care during the armed conflict with the basic humanitarian concept of distinction, parties that to an armed conflict must distinguish between combatants and non-combatants. And for more than a decade of contemporary conflict, DoD and the U.S. government writ large has sought to build and institutionalize best practices that go well beyond baselines of international humanitarian law. I talked about that the President has signed an executive order for the civilian casualties, and we also work to have best practices to protect civilians in our operations and directs the sustainment of these measures in present and future operations. So I think this current administration has done a lot with executive orders and statements to highlight the importance of protecting civilians and non-combatants. I want to stress that the executive order provides an example that can serve to inform the relevant practices of other nations. So as we talk about the protection of civilians and non-combatants, we now as a government have a document that other countries can look at. And when you look at the Geneva Convention and all the international humanitarian law, you have to be a lawyer to sort through and sift through everything between our EO and civilian casualties, protection of civilians, and from our statement of principles for medical facilities. I think we tried to highlight like one-stop shopping areas of our principles and our values for our government and department. The statement of principles, as I talked about on October 3rd, 2016, this year, the Secretary of Defense issued the statement of principles related to the protection of medical care provided by impartial humanitarian organizations during armed conflict. That's the full name. It's on our website. There's a link on www.defense.gov. It's under news and publications. We can give that to you if you'd like to see it. And that memo went to all the services, DoD agencies, and combatant commands, directing them to ensure the orders, rules of engagement, and directives, regulations, policies, and procedures are consistent with the principles. We realized after that unfortunate mistake of Kunduz, we had lots of briefings with MSF, with non-governmental organizations, and they understood that Kunduz was a mistake, but the clear message to us as a department is, what can we do more? How can we help not only our own military highlight the importance for this, but show an example of what we can use with other militaries and other governments to highlight. So that's why the statement of principles came about. We didn't come up with anything new. It's all the things that we were already doing and inherent to international humanitarian law, but it highlighted for us to stress the importance to our force of how to conduct and operate, and also it's something we can use with our partners. So I'd like to say that the cooperation, as Stephen mentioned, that I worked on Africa. I helped establish Africa Command, and there's a lot of concerns with that. I'm not here to talk about Africa, but sometimes MSF and other NGOs don't always want to deal with the military. And then when the unfortunate Ebola outbreak occurred in West Africa, MSF was one of the many NGOs that said, we need the Department of Defense to help in this. And the Department of Defense came and helped in Liberia and West Africa with the support and concurrence. So I would say at that point, our relationship between DoD and MSF was at its height, and then the unfortunate incident of Kunduz put a strain on that relationship. But I say at the headquarters level, between the Department of Defense and many NGOs, we have a greater understanding through all of these activities, good and bad, and lessons learned that we have that we will move forward on. So I just wanted to highlight that. I also want to highlight again the deconfliction and working with humanitarian organizations. The Department of Defense works closely with UN OCHA, the Office of Coordination for Humanitarian Affairs, and whenever there's a focal point of civ-mil coordination, it's with us, with OCHA, and OCHA has communication channels with our combatant commands and try to help, and many of our combatant commands where we have areas of operations are working with non-governmental organizations so that MSF and other NGOs can highlight where they're at, where they're operating, with, especially with medical facilities, so we can increase and enhance that communication so that mistakes don't happen. So I'll leave it at there, and thank you very much.
Thank you very much, Mark. Zahir Sadou.
Well, good morning. I'm really honored to be here and among this esteemed panel, and I recognize my friend Len Rubenstein from Johns Hopkins, and thank you, Steve, for inviting me. And I think CSIS was the first think tank that addressed attacks on healthcare in Syria in 2012, early in the crisis when no one was paying attention to that. And I'm Syrian American, so most of us in the Syrian American community are traumatized because of what's happening in Syria. And I wake up in the middle of the night and I tweet at 3 a.m. About attacks on healthcare facilities in Syria. I remember the first time that I tweeted about chemical weapon used in Syria in December of 2012. And I contacted the National Security Council at that time, and they said that we are very concerned. Let us know what happens. I remember the first time I tweeted about the attack in Ghouta in August 23rd, 2013. I communicated with the National Security Council at that time about this sarin gas attack and the fact that we have influx of large number of patients who are suffocating with very limited capacity in East al-Ghouta that has been under siege for the past couple of years by the Syrian government, and they were very concerned. I remember one time tweeting about attacks by ISIS or ISIL on a medical facility that SAMS has in the city of Mar'a, north of Aleppo, and the fact that the doctors over there were very concerned that they will be slaughtered by ISIS. And actually, our National Security Council and Ambassador Power paid personal attention to that attack at that time, and it was averted, luckily, and the physicians were saved. So to me, it's very personal. I think most of us now seeing what's happening in Aleppo, especially the ones who've been in Aleppo. I've been in Aleppo 5 times. Last time was just before the siege, this coming siege. And I worked in an underground hospital that's called M10. I think Ben covered that hospital in his article. It's built underground for protection because it was bombed a dozen times in the past 4 years, and that's why you go at 20 meters underground, and you see doctors and nurses and emergency room and ICU and operating rooms, similar to any other hospital in Chicago. I practice in one of the best hospitals in Chicago, but it is underground, and we saw patients, mostly civilians, at that time when I was there. And I remember this woman, her name was Fatima. She was pregnant in her 3rd month, and she was in her house, and when a barrel bomb fell on the house and killed her older son, Abdu, who was 9, and younger daughter, Iraf, who was 3, and she had internal bleeding, and she lost her unborn child, ended up on life support, and she had only one surviving son, Mahmoud, who I saw in the emergency room, and I was trying to talk to him, and he could not smile. And every person I saw in that hospital was traumatized, including the medical staff. And so, this is something that is affecting, of course, not only patients, but also medical community. I spoke with one of the nurses a couple of days ago in Aleppo. I don't know if she's still alive or not. Her name is Bara'a, 24 years old, who did not wasn't a nurse before the crisis. She was a medical student in Western Aleppo. She had to move to Eastern Aleppo because her family is there, and because she could not continue her medical school, she had to go to a crash course in nursing, which SAMS, my organization, have provided. We had a nursing school that is built underground in Eastern Aleppo for protection. And she completed her course and became a nurse in a hospital called M2 Hospital. And these are code names for hospitals that are already established. These are hospitals that have been in Aleppo before the crisis. And I visited 7 of them. Each one of them was bombed multiple times before the crisis. And sometimes we have these trolls on Twitter who will tell you how many times this hospital was bombed. You've mentioned that it was bombed before. When a hospital is bombed, it's not destroyed from the first time. So the Syrian regime and the Russians lately have been using much more extensive power to destroy completely these hospitals. M10 hospitals was bombed with cluster bombs, with incendiary bombs, and eventually with what's called bunker buster bombs. So it completely erased the hospital from the ground. This is a hospital that has been providing 4,000 life-saving surgeries every year before it was completely destroyed. So Bara'a told me that right now the situation is beyond description. She said death is better than what we are living through. Aleppo has been under siege for 4 months and a half, no food, no medicine, no diesel fuel, no fruits, no vegetables, no baby milk. So people are starving. And they are bombed every day by not only the Syrian regime, but also by the Russians. And she told me that we had only one small facility left, and we are crowded. We had 500 patients one day, and we had surgeons who are operating on the patients on the floor of the emergency room, opening their bellies. And we had patients who are dying not only because of injuries, but also because of extreme cold, because it's cold in Aleppo right now, and they do not have enough blanket to cover these patients. And she said the worst thing that happened to any person in Aleppo right now is to be injured, because being injured means that you're going to die. Even if you have a patient or access to a patient, a physician or a nurse who will treat your wound, the likelihood that you will get infection or die from cold or from malnutrition or bleeding, and you don't have enough supplies at that time is very high. I was looking at some of the pictures yesterday from this group of civilians who were fleeing Aleppo, and they were bombed while they were fleeing. And there was this child who was 12 years old who was wearing a red coat, and she died, and she had a broken leg. And I look at this picture, and I wrote in my Facebook that death is probably more merciful than the empty words that we are hearing and tweeting about, that we care about civilians and we care about healthcare. Because to me, in spite of all of the panels that we're doing in the last 5 years, nothing has changed in Syria. If anything, it's getting worse. So we're talking about systematic attacks on healthcare. And numbers do not mean anything, by the way. We're talking about all of these numbers. Physicians for Human Rights have documented by the details the attacks on healthcare facilities and doctors in Syria. More than 750 healthcare workers were killed. More than 350 or 60 hospitals were bombed. Every 17 hours, there is a healthcare facility that is bombed in Syria in the last 2 months or so. In the last 144 days, 143 facilities and healthcare workers were attacked in Syria. Every 60 hours, there is one healthcare professional who is targeted in Syria. And in spite of all of these numbers, in this post-number or post-fact or post-truth world, there is no action. How did that started? I mean, I remember in August of 1988, we had a graduation ceremony from Damascus University Medical School, and at that time, I had to give the graduation speech, there was this person who was tall, and at that time, he was not well known. I mean, he was known to be the son of the president, but he graduated in the same class, and he took the Hippocratic oath that we as healers should care for all people who seek treatment, whether they are our friends or foes. And he received an award for his quote-unquote leadership. He happened to become the president of Syria, Bashar al-Assad. At that time, he was not known to be ruthless or brutal. I had several meetings with him when he became a president. At one point, he said he wished that he would have been a physician, not a president. At one point, he said that I asked him whether he will be introducing democratic reforms in Syria. He said Syrians are not ready for democracy. And I think he still has the same views at this point. When you listen to his speeches, besides the fact that he has no remorse to what he has done in Syria and the fact that he has no sympathy to the civilians and the refugees, he uses medical terms in his speeches, unfortunately. This is a person that is a physician, graduated from Damascus Medical School, who had training to be an eye physician in United Kingdom. And I remember visiting an eye facility in Aleppo that is underground, and many of the victims were children who had eye problems because of shrapnels in their eyes. So he uses these medical terms in his speeches, the fact that there are 70,000 germs, he said in one time, in Syria that they need to be eradicated. And one time he said that if you are a surgeon and you have blood on your hand, it doesn't mean that you are a murderer. So it looks like he believes that he's fighting the good fight. And I think what started in Syria, the fact that the government, taking cues, by the way, from our own government, attacking, using the card of fighting terrorism to terrorize civilians and to attack healthcare professionals and take it as a blank check to kill everyone who they perceive as a terrorist, including hospitals and doctors and nurses. And I think this is something that we really have to care about, because people and countries take cues from us. And if we use fighting terrorism to attack doctors and nurses and hospitals, then other countries will follow our lead. So I think Leon Banata in the morning session was talking about the fact that we have to provide in the next phase more leadership and less talk. I think that's really what we need to focus on. More leadership, moral leadership, because that's the fact that the United States was great and is great, is because of the moral leadership that we had in the world. And right now we are lacking this moral leadership. I remember Dr. Hassan A'raj, I met in what's called the Central Cave Hospital in Syria. This is a hospital that is dug in the heart of mountain in north of Hama for protection. And also because the village that Dr. Hassan Al-A'raj, who's a cardiologist in that city, refused to have a hospital in the village. They said, if we have a hospital in the village, that means we will be bombed. And we don't want that to happen. So he went to this mountain and he dug this hospital in the heart of mountain. Inside the mountain, you think that you are in the middle of one of the most advanced hospitals. This is a hospital that was built with the support of SAM, Syrian American Medical Society. But outside you will see a mountain with no people around it. And this hospital was bombed lately, and Dr. Hassan Al-A'raj was killed in his car while he was leaving the hospital to his home, and he was the only cardiologist in town. We are talking about the global refugee crisis. Global refugee crisis is because of the attacks on healthcare. When you do not have a doctor in town, you will not have town. People leave if they don't have physicians or nurses who are taking care of their children when they are sick. When you do not have a nurse in a neighborhood, you will not have a neighborhood. The fact that we have 5 million refugees from Syria is because of this attacks on healthcare, on schools, on fruit markets, on civilians. And in order to take care of this refugee crisis, and Syrians do not want resettlement of refugees in the United States. They care about our fears of the aliens. But they want these people to stay in Syria, but providing protection for them. If we can provide protection, safe zones, for civilians in Syria, by protecting their hospitals and their schools and their neighborhoods and their fruit markets, they will not leave Syria. So I think President Trump, in one of the election debates, he mentioned that one of his policies in Syria is to provide safe zones. I think this is a welcoming policy, and I think having safe zones in Syria is something that we are calling for, especially safe zones for hospitals and doctors to practice medicine. We had in the Syrian American Medical Society to deal with all of these challenges, and we felt that it's our duty as physicians, as humanitarians, as people who came from Syria, to do what we can to provide health care to the civilians in Syria and to be the advocates for the doctors and nurses under attack in Syria. We started cross-border relief from Turkey to northern Syria, from Jordan to southern Syria, with the help of the Turkish authorities, the Jordanian authorities, with the help of our State Department. We had to work within coalitions like Safeguarding Healthcare and with our friends in MSF and other international NGOs like IMC and IRC. We had to use technology, so we have telemedicine that connects hospitals in Syria in under siege areas. We have 1 million people under siege in Syria, by the way, by their own government. Hospitals inside Syria connected to specialists in the United States through using telemedicine and simple applications like WhatsApp and Viber and so forth, where every day I look in the morning and I see these questions and pictures of x-rays and CT scans from doctors inside Syria asking questions that I have this patient who had bleeding into the brain, what should I do with? And then we have doctors from the United States who are responding to them. Why don't you give this medicine or that medicine? Unfortunately, in the last few weeks, especially in the Aleppo, the options for treatment is very limited, because even if you tell them do this or that, they do not have access to medical supplies or to medications. Well, I think I can stop at this point, and maybe we can address other issues.
Thank you.
Thank you.
Thank you very much, Saya. Ben.
I'm delighted to be here, and thank you for bringing me in. I also am very glad that Dr. Sahlul detailed some of the horrors in Aleppo and in other parts of Syria, because the situation that he was describing is something that I'm going to address in a slightly different context, which is that everything he described is a war crime. Basically, international criminal law is a fairly new endeavor. It was conceived really by a British lawyer following the horrors of the First World War. A man named Hugh Bellot spent years beseeching the League of Nations to establish an international criminal court at The Hague to prosecute war crimes and what he called all offenses committed contrary to the laws of humanity. And for Bello, allowing the outrages committed during the war to go unaddressed was as dangerous to humanity and civilization as the atrocities themselves, but his efforts fell short. It took the Holocaust for the international community to set up the world's first international war crimes tribunal, the Nuremberg trial, and another half-century of atrocities in South America, Asia, Africa, and Eastern Europe for his vision to be fully realized. In 1998, after widespread killing in Bosnia and Rwanda, the UN drafted a treaty in Rome which created, what was called the Rome Statute, which created the International Criminal Court. And in theory, the UN believed the very existence of such a court would give pause to dictators and warlords prone to brutality, because perpetrators living anywhere in the world could be hunted until their dying breaths. As we have seen recently, effectively, this hasn't worked because international criminal law is a relatively new and fragile endeavor, and to a disturbing extent, its application is contingent on geopolitics. If a country, for instance, has not ratified the Rome Statute, then the ICC has no immediate automatic jurisdiction over crimes committed in the territory, which is why Syria has not ratified the ICC document, the Rome Statute. Neither has Russia, neither has the United States. As a result, the International Criminal Court has no automatic jurisdiction over crimes committed in that territory, and the only means to refer jurisdiction are through the UN Security Council. But if anybody vetoes a measure to refer jurisdiction within the Security Council, then there is no jurisdiction granted, which is why in 2014, when the Russians blocked it, the ICC has no jurisdiction to, the measure it proposed was to allow the ICC to investigate all war crimes committed by all parties at a point in the war where it was very, very clear that war crimes were being committed by several parties, most vociferously by the government, but also by the Islamic State, also by certain rebel groups. The challenge with prosecuting rebel groups is that there is less of a clear chain of command, and international criminal law is interested in high and highest level offenders, and it may be difficult when you don't have a clear chain of command to prosecute, to get the interest of the international court for some of the crimes committed on the ground. But in the case of Syria, at this point today, the body of court-ready evidence against top officials in the Syrian regime is, including Assad himself, there's documents with his signature on them that implicate him in some of the crimes, which I'll detail in a moment. The body of evidence is more complete and damning than has previously been collected during an active conflict, any active conflict in history, and yet there is no clear path to prosecution. So what are we talking about when I say body of evidence? Essentially, one of the challenges for example, prosecuting the atrocities, the systematic targeting of hospitals in Aleppo, is that it's pattern evidence. You have this clear pattern that they are being attacked. It is clearly part of a plan, but you don't have individual criminal responsibility. Who do you charge with those crimes? If you have evidence that it's a specific branch of the Air Force intelligence, perhaps you can trace it up to Jamil Hassan, who's the head of Air Force intelligence in Syria. But you need some sort of internal regime documentation, ideally, to be able to trace crimes on the ground that are systematic and widespread to somebody who can actually be charged with the crime. And so that's where the kind of evidence that was collected by a group of war crimes investigators who I profiled earlier this year comes into play. This is a group called, basically in late 2011, a former investigator for the International Criminal Court and several other tribunals named Bill Wiley was approached by the British government, and he was asked if he could train some Syrian activists to document human rights abuses in Syria, film airstrikes on hospitals and civilian areas, and this sort of thing. And he said, no, I have no interest in doing that because it's going to put them in danger, and it actually is kind of, while it's useful for messaging and getting attention to these crimes, it's actually useless in court. And you're going to have all these young guys going out and young men and women getting blown up because they're getting too close to the action, filming things that don't actually serve a trial, because proof that an airstrike happened on a hospital does not give you individual criminal responsibility, and you can't actually charge someone with the crime. So instead, he trained these activists and lawyers, all Syrian, to collect the kinds of evidence that would actually serve a trial. He told them they forged relationships with rebel groups that at the time in early 2012 and 13 especially were taking large swaths of territory from government troops, and the government intelligence agencies were leaving behind their buildings, their headquarters, with vast troves of documents. Some were intelligence communications coming straight from Damascus. Others were these security committee meeting minutes from governorate security committees that had been following off of orders from Damascus. And then he also collected, Wiley's group also got a hold of a large collection of documents that had been smuggled out by a mole within Assad's highest level security committee, who has gone public, and he now lives in Turkey. And they were able to rebuild the chain of command and trace the systematic torture and murder. After smuggling 600,000 Syrian government documents out of security and intelligence facilities, Wiley's group, the Commission for International Justice and Accountability, was able to trace the systematic torture and murder of tens of thousands of people from detention facilities in Syria to an order that was drafted by Assad's highest level security committee, approved of and signed by Assad himself, and then sent down the chain of command for implementation in distant provinces. So that's the kind of evidence that actually serves. And the important point here is that the most incriminating evidence against the regime has been produced within the regime's own immense bureaucracy. Not just these documents, but you also have the Caesar photograph collection, which I'm sure many of you know about, which I will leave for another time to sort of move along. Now, another important point, as Jason Cohn mentioned, the Geneva Conventions, the Rome Statute, are completely unambiguous about what a war crime is. It is not hard to read the list and say, oh, there's really not much question about whether something applies. For example, there's two broad categories: crimes against humanity, which this was what the ICC should have jurisdiction over, broadly speaking. Crimes against humanity is a set of acts committed as part of a widespread or systematic attack directed against any civilian population. And that includes torture, murder, rape, enforced disappearance, illegal imprisonment, persecution, and other inhumane acts. There are a few other crimes against humanity, but those are the ones that are clearly happening in Syria. There's no question about this stuff. War crimes apply only during an active conflict, of course, because by definition it has to be committed during a war, whereas crimes against humanity can be committed even if there isn't a war. And that includes some of the ones that the ICC ought to be afforded jurisdiction over in Syria, would be willful killing, wanton and excessive destruction of property beyond military necessity, compelling prisoners of war to fight on behalf of their captors, intentional airstrikes directed against civilians, intentional attacks directed against humanitarian personnel, installations and vehicles, bombardment of undefended villages or buildings, murdering prisoners of war, intentionally attacking markets, schools, and hospitals, mutilation, pillaging, the use of chemical weapons, including asphyxiating gases, and intentionally starving civilians as a method of warfare while willfully impeding relief supplies, all of which is happening throughout the country, but very, very, very obviously and very well documented in Aleppo. Another crime against humanity that this word is often used, but then put with great caveats whenever someone says, oh, the crime of extermination appears to be happening in Syria. Often journalistic publications will sort of mention that and then say, according to somebody, and frame it as an opinion. But if you actually look at the Rome Statute, extermination is very clear. It's deprivation of access to food and medicine calculated to bring about the destruction of part of a population. There's no question, again, that this is happening on a widespread and systematic scale. So the problem is that without any jurisdiction and with basically international humanitarian law, international criminal law, functionally doesn't apply. And when the Rome Statute, while it was drafted as a guideline of exactly what you cannot do in war, when there's no path to prosecution, it seems by the Syrian government and by the Russian military to have been taken as a guideline of exactly how best and most efficiently to exterminate your opponent with no consequences. And what we're seeing now, because there are no consequences, the broader consequences of having no consequences, that we're eroding the credibility of the court by Russia's political obstruction at the UN Security Council level. And that really is part of what feels this year very much to be a sustained attack on basic human principles and values that underlie the institution itself. If you create this sense that everything is too confusing to prosecute, to find any truth within it, claim that in spite of all sorts of evidence that none of it is sufficient or all of it is propaganda, then there's really no clear path. By calling into question the belief that justice can be defined and applied fairly and universally, that there is such a thing as truth that is not propaganda, that there are basic human values, that the application of justice is anything but political, and to create a climate of confusion to bring about a climate of impunity. And basically, if human rights don't matter, then what does? A recent example, last week or a couple of weeks ago, Putin announced that Russia was withdrawing from the ICC, which they were never a part of the ICC in the first place. So this created a bunch of headlines that said that Russia's withdrawing. It allowed him to say, Putin to say that the court was being used politically and had no credibility in the first place. And then as a result, triggered other defections, like Duterte in the Philippines piggybacked off Putin's announcement and said that the Philippines agrees that the ICC has no credibility. So basically, in summary, the Western countries in the UN have spent the past 5.5 years condemning atrocity after atrocity to no avail, and with justice so limited by geopolitics, who in Syria is afraid of international law.
Thank you. Well, you've all been very patient. Those are four powerful presentations. We have only a few minutes left, and I want to offer you the opportunity to offer some comments and questions. And so what we'll do is we'll collect 4 or 5 of those and then come back for our panelists to close. I believe we have microphones to share, and my one request is keep your comment or question to a single comment or question and keep it very short. Len, start here and speak into the microphone, please.
Hi, thank you. This is a question for Mr. Swain. It's really true that the U.S. has provided a lot of leadership since the Kunduz attack, but there's been a concern that the order, the principal statement from October, focused exclusively on humanitarian organizations. As Jason said, most of the attacks are not on local health providers, and as Zahir said, the excuse is counterterrorism. And there's a real need for U.S. leadership to make it clear that counterterrorism cannot be an excuse for attacks on civilian doctors. And so I urge you to consider expanding that statement, which is now so narrow. It's great to protect MSF and International Medical Corps, that's fantastic. But the local victims, the local doctors and nurses, who are the majority of the victims, are not protected by that statement. And we need that. We need that because of the counterterrorism excuse for attacks. And I'd love if you could address that.
Thank you. Hold for a moment here. Over here, please. Dean is right behind you.
Thank you.
Please identify yourself.
Yes, hi, I'm Judy Seltzer, a principal with Management Sciences for Health in Boston. It's a shame somebody from the World Health Organization isn't up there, because in a way, they're a perpetrator here. We deal with health system strengthening. I'm a public health professional, and what happens is we come up with...
Please be very
yes,
succinct.
with the current model of the Global Health Security Agenda, which has a number of technical areas and foci, it's very much obscuring human atrocities. It deals with One Health, with animals and humans, and disease outbreaks and their prevention. But my concern is, what do you think we can do about creating greater collaboration between those working in defense and those working in public health, so that we speak the same vernacular? Because what you can't count, you can't actually have a case definition.
Thank you. Right here. And then Keith, we'll come back to you, Keith. Yes, please identify yourself. Please be very succinct.
Frances Vesey with Answer. I've often thought that the Syria conflict is kind of a prime example of no good options. What are some positive steps that you think that we can take going forward to shape the conflict in a way where there's kind of a way out that would be positive?
Thank you. Over here. And we'll take one more after that. Keith?
Keith Martin, Consortium of Universities for Global Health. Thank you so much for what you're doing. We know we have a responsibility to protect without an obligation to act. My question is, what can we do right now, specifically, to be able to stop the killing, given the urgency of trying to save lives on the ground right now in Syria, to be able to create the humanitarian corridor, the no-fly zone? What prescription can you give to us, and what we can do now to save lives in Syria now?
Thank you. Keith, just hand the, yes, right here, right behind you. Thank
Eric Van Giesen, National Strategic Research Institute with the University of Nebraska. I am just wondering, how can we differentiate instances when terrorists are hiding within health facilities versus when the health facilities are not harboring, legitimate threats to security?
Thank you. I'm going to start with Mark, and we're going to work our way down the row here, and then I'll offer some closing remarks. Mark.
Sure. Well, I'll start off with the first question. Thank you very much, sir, for that. And I think I just have to respectfully disagree with you on our statement of principles. It's principles related to the protection of medical care provided by impartial humanitarian organizations during armed conflict. And it talks specifically about medical care provided during armed conflict is an activity that is fundamentally of neutral humanitarian non-combatant character, and it has descriptions of all the wounded and sick. And this was not aimed at any one organization. It was a statement of principles of how the Department of Defense conducts its business and respects that the neutrality of the medical community. So I don't feel that I agree that it was just for some, and all medical facilities and those health professionals who are working are what we are focusing on. So thank you, sir.
Jason?
Maybe I'll answer the last question a bit. It's really a twofold responsibility, right? It's a responsibility of combatants not to take over hospitals, to turn them into command and control centers, and it's also a responsibility of humanitarian organizations, medical groups, when possible, to acknowledge when the places that we create to heal are being used for other purposes. But the key fact in all of this is that the responsibility of combatants to issue a warning, even if a structure has lost it's protection because it's being used for other means. It doesn't preclude the responsibility to look at questions of distinction, proportionality, and warning. And that is something actually that is quite clearly addressed in all of the international humanitarian law, but also in the unilateral statement from the US government on the Statement of Principles. So the burden does not somehow shift in any way. It actually means very much with the combatants on the ground, but also those who are looking to strike a facility that has maybe lost its protection because it's being used for other purposes. I'll pass on to some of the other ones.
I think the two questions are related, but I think the most important thing that at one point during the Syrian conflict, our government set some red lines, and actually we respected these red lines. One of them about the Kobani, when we said that ISIS will not take Kobani, and we actually assisted at that time the Kurdish group to protect the city. And at one point, the Syrian regime attacked American troops or allies in Hasaka, and we said, next time you'll attack us, we will attack you. And actually that attack stopped. So I think enforcing certain red lines about Aleppo, which is much bigger than Srebrenica or Sarajevo, is important. And I don't know how can we get this political will to act. In spite of all of our effort in the Syrian American diaspora, meeting with the White House, with the State Department, it doesn't look like it's moving them to action. And I think there's should be a move from analyzing and so forth to making decisions. The main confine of the current policy on Syria is de-escalation. I don't know if that works with Putin or Assad. So protection of Aleppo, protection of civilians should be a priority, which means sometimes you have to challenge certain bad actors. The secondly is engaging the Syrian American community that is very resourceful, that knows the landscape, that is connected to the ground, that is the factor that will be moderating Syria in the future. When we're talking about the fight against terrorism, it's not by bombing only. You fight terrorism by people who are perceived as leaders, as moderate, and doctors in Syria are perceived as moderate leaders. And if all of these doctors leave Syria, then you will have only left with the extremists, which that means you're going to bomb Syria for the next 20 years or so. So it's very important to preserve these human capitals, the natural leaders in Syria. These are the cream of the crop of the Syrian society. Engaging Syrian diaspora in policy making, listen to them carefully and take their advice seriously, whether it's related to issues related to terrorism or related to protection of healthcare, and involve them in the post-crisis recovery and rebuilding. You cannot rebuild Syria and stabilize it without the involvement of Syrian doctors and Syrian American diaspora.
Thank you. Ben?
I guess I would just very briefly say that, for instance, I very much admire the DoD's commitment to adhere to principles of international humanitarian law. The challenge for international criminal law and humanitarian law as a whole, though, is not just dependent on the United States adhering to it, but the UN Security Council and all countries on the UN Security Council enforcing it. And adherence, while good on an individual level, doesn't completely negate the erosion of principles by actors that refuse to adhere to it.
Thank you. I'm going to offer just a few closing remarks. First, I want to thank our four speakers for taking the time to be with us today and for preparing such careful, thoughtful remarks, and for your leadership and your commitment on these issues over many years. We're really in your debt for all of the work that you've done. A few impressions from this discussion. One is the nature of war, the complexity of the battlefield has changed. What we've seen, not just in Syria, but in Yemen, in Libya, in Iraq, is that the coexistence of counterterror, aerial bombardment campaigns, limited military presence on the ground, the intermixing of humanitarian organizations in that battlefield makes for extremely complex situation, limited leverage, particularly over the Russians and the Saudis, in terms of the aerial bombardment practices. If you could move the Russians and Saudis to change their practices, you could probably alter some of what we've seen as indiscriminate and targeted violence against civilians and the like. But we need to take account of how war has changed in these settings and how complex that battlefield has become. A second is what we've heard today are some substantial gains. SAMS has led the way with a coalition of partners in erecting a very extensive network of infrastructure of health in the midst of a terrible war that serves 2.5, 2.6 million people. That's a staggering achievement. It's one that builds off of the power of the constituency of the Syrian American community here. And that is quite new, quite impressive, quite important for us to acknowledge. The data that has been collected, what Ben emphasized, this remarkable initiative that's been undertaken that, to my mind, is unprecedented. But it's been matched by efforts by MSF, by WHO, by IC, International Committee of the Red Cross, to document and bring forward in a systematic way that data to the Security Council. That's important. The DoD-NGO dialogue has improved significantly. And it's through the, and I think it's been through the trauma of what happened in Kunduz, the awareness of what's at stake, and the good faith efforts of parties on both sides. And I think that needs acknowledgement and needs to be commended. These are really tough decisions, and I think people have risen to the occasion and intensified those dialogues. I've heard that from both NGO and from DoD side. I've mentioned the power of the diaspora. There are live options. Obviously, there's the question of what does the new administration do about this? Well, we don't know. It's too early to tell. But clearly, there have been signals around changes with respect to Syria. There's been signals with changes with respect, ambiguous and sometimes conflicting signals around Russia, around counterterrorism approaches and the like, and we need to watch and be careful. But things are not fixed by any means, and it could carry us in any number of directions, but we need to acknowledge that. Safe zones, we've heard a lot about safe zones. We've heard a lot about special representatives, new mechanisms, coming back to the International Criminal Court. All of those issues are highly problematic for the reasons that we heard today, but they're not going away. There will continue to be deliberations around what kind of accountability mechanisms can work under these political circumstances. We're not done with that debate, nor are we done with the safe zone debate and the debate of what will this next administration see as opportunity or acknowledge as the gravity of this situation. And I think it's very important that the type of stories that all of you have told us today continue to be told in a live and coherent way in this next period in which thinking and deliberations on these issues are going to move forward. The last thing I'd say is we haven't talked at all about Mosul. We haven't talked about ISIS. We haven't talked. This is an era of what Aleppo has shown us is an era of a tragic, large urban environments being decimated on a scale that was unimaginable just a short while ago. And we now have the active issue around Mosul, and we have similar predicaments in Yemen and elsewhere. And these are challenges that we need to think about very hard in this next period. And maybe our next session will focus on those. Those are complex unto themselves. But on behalf of everyone here, let's please thank our speakers for coming today. Thank you, Dean, Lily, Chris. Thank you so much for all of your help. If we have time, we'll show the video one more time. I'm not sure if we do have time. We're low on time, so sorry. Watch it online then, please. Thank you. Thank you.